Dr. Eugene Lipov, welcome to the Pain and Performance Podcast.
Good morning, sir. Appreciate having me on.
Yeah, I'm excited to dive into this. I've been making my rounds through the second read of your book and jotting notes and certainly kind of getting it to patients. One of the things I wanted to start with, because y'all kind of start the book off in this, is what are some of the symptoms, like, so your co-author Jamie Mustard kind of talks about how he started finding his way to this, and he didn't think that he had trauma per se or a post-traumatic kind of symptoms. And then when you start looking at it and diving deeper, I think we realize a lot more people are in that camp than maybe they would say to themselves. So, what are some of those things that he presented to you with, and that most of the patients come with in terms of symptoms that maybe the regular listener would not immediately associate it with post traumatic stress?
Well, I usually like to give a direct answer, but let me give you an obtuse answer. So the whole term, and I'll tell you why. So there is a bit, the term PTSD, post-traumatic stress disorder, is only one of many terms that we use. The first term in the modern era was soldier's heart, which was descriptive. The heart was beating. This was Civil War, so you can see how long it goes back. And it's been changed, a number of things. So if you look, so it's physiologic, right? So the physiology. It's the doctors used to be really good at observing and go, this guy is pale, his eyes are yellow, something's wrong with the liver. Observation, right? Not a construct. So in 1980, psychiatrists decided to come up with the term PTSD, post-traumatic stress disorder, compendium of symptoms, and I'll tell you what the symptoms are. But if you read that carefully, it's interesting. In order to be diagnosed with PTSD, you need to have a occurrence or trauma outside normal human experience, military trauma, severe rape, things like that. So if you look at that perspective, what Jamie had, he had multiple small traumas because he was abandoned in LA as a child. He had a lot of multiple additional traumas, which really is problematic. So he had symptoms of hypervigilance, looking around, um, can't sleep. You have uh, short temper, short fuse, impulsivity. Those are some of the very basic ones. So that's actually why one of the things we'll touch on is we're trying to change the name to post-traumatic stress injury. There is a brain change that happens. In fact, that doesn't just happen in humans. It happens in rats, it happens in dogs. In fact, I successfully treated a dog with PTSD. It's called VPTSD actually in military, veterinary PTSD. But
Yeah.
there are experimental models for rats to induce PTSD. So, and their symptoms look the same. They become either withdrawn or they become aggressive. They can't sleep and they get depressed. So the point is, it's not just a human condition.
Yeah, I love the shift, the mind shift in the name change, and I'd really like to kind of dive into that. It kind of, even whenever I think about a disorder, my brain goes to a place where this is something that, like, we can't really change easily. It's a disorder. Some of that is like, just your kind of subjective thoughts about it. But when you hear disorders, it's almost like we don't quite know what's going on with it. When we hear injury, I immediately start to say, like, well, we all know how to heal injuries. Like, we all have them constantly. And if we do the right things and we get the right treatment, injuries get better much easier. Even whenever you mention it in the book, I was like, it's just such a tiny shift that creates a huge change in the way we think about some of these things.
Oh, you're 100% right. But it's interesting if you think about disorder, it implies you can snap out of it. Like, oh, I don't feel like having PTSD today. Nah, it's over. Well, that's not true. Obviously, people who've had it or who have it are not wouldn't agree with that you can just snap out of it because that's crazy. But that leads to stigma and shame. Stigma and shame then leads to not seeking help, and it leads to loss of hope and leads to self-harm. So that's a direct line that many people have been arguing since 2009, actually, In 2012, there was a huge meeting between APA, a four-star general who was in charge of suicides with the Army, and Frank Ogberg, who's my friend and who wrote, very kind. He was very kind to write a foreword to our book. But our whole thing, if you go to my website, dreugenelipov.com, you can see our PSA, public service announcement. Basically, it says there's no difference in PTSI and a broken leg. Broken leg, you're going to go see a doctor, take an x-ray, go get it fixed. But the assumption is that PTSD is invisible. People call it invisible wound. My answer is it's invisible if you got the wrong scanner. If you got a functional MRI or a PET scanner, you can actually see it. And you can see the reversal of that. So if it's an injury, you can fix it. You just need the right tools. And that's where I
Yeah.
come in. I just happen to have a tool that works for that.
So when somebody's having those symptoms, you're talking about, certainly a lot of this data comes from the armed forces because they are involved so much in trauma, but we're talking about, having, kind of temper, anger issue, racing heart, sleeping problems, like this whole cluster of things. What's happening inside their body from the injury? What's going on kind of physiologically in there?
Fair question. So before we get into that, I'd like to only comment on one thing. The most common group of people with PTSD or PTSI are abused women. They're 10 times larger than all the military personnel with PTSD or PTSI. So just keep that in mind. But physiologically, let's talk about what PTSD or PTSI is. So trauma occurs. We're not talking about physical trauma. We're talking about seeing somebody killed in front of you, anything like that. Brain, and it's actually, we have great diagram in the book that we were able to put in there. The brain activates a part of the brain called the amygdala. So it's fight and flight. If you have a gazelle out in the prairie and they hear a click, they think the tiger is about to eat them. So they start running because the amygdala says, hey, you're going to get eaten. It's time to run. And it continues to run. And it's looking around so it doesn't get eaten, right? So that's, looking around is, technical term is hypervigilance. At the same time, a substance is produced called NGF, neural growth factor. It's called neurotropin, which makes things grow. So it goes from the brain and is transmitted through the fight and flight nerve or sympathetic nerves to the neck. Whether it's a ganglion, the nerves are combined here, which is control the sympathetic fibers. Once it hits here, it promotes sprouting. The new sympathetic nerves grow in the brain. That's been shown in the rat model, actually. So if you think about it, so before the trauma, you got 4 nerves, now you got 8, right? Each nerve produces norepinephrine, which is like adrenaline. So in fact, if you had the fluid, take the fluid around the brain in a soldier with PTSD, the norepinephrine level is twice as high as it should be. So we know that happens in humans. And then as long as it stays like, as long as the NGF is in this part of the ganglia, that's maintained. And that could last for years. So then we do and I do something called stellate ganglion block or dual sympathetic reset, which is the more advanced version of it. And we've treated, I'll give you an example of a guy who was involved in Vietnam battles. He had a horrible time there when he was 17. I met him when he was 73. So we did the block. And 10 minutes later, he came out crying like a baby for 30 minutes. I was like, oh my God, I broke this poor man. Turned out he was crying because he has not felt an emotion for 50 years. He actually felt emotions first time ever. Let's talk about what happened in the brain. It's kind of interesting. So you had the 8 nerve fibers, right? So when we do the block, it leads pruning. Pruning means taking away. He took away the extra nerve fibers. So 2 things happened. The first thing happened immediately, which is norepinephrine level dropped in 10 minutes. That's why he felt better immediately. But the secondary effect was this took it away. So we're in touch with that man, and it's been about 6 years. He's still feeling very well. So the way what we do is we put local anesthetic, and for whatever the reason, it takes away the NGF, which is required to maintain this growth. That's why local anesthetic in the neck that lasts 8 hours can last for years.
That's amazing how much our body adapts to the trauma. So if we're, we hear of these things where people are like, adrenal fatigue and that whole cluster of symptoms where sympathetic dystrophy in terms of people in today's world constantly feeling like they're under attack, being under stress, and they can't adapt to that. But if it's a physical change in there where we've actually adapted those nerves to make it easier for us to get a stress response, is that correct?
Yeah, if you look at, if it's a lot of times people blame our bodies for kind of failing us, right? But if you think back, why is it there? But look at it from perspective of caveman. Let's say you're a caveman and all of a sudden the pride of tigers decide to come by and hang out with you, right? So you have to start being able, you see a tiger, you go, oh, I'm gonna get eaten. You start running. So what happens in the body is that your heart starts to beat stronger. All the blood vessels for non-essentials part, like your fingers and your toes, shut down because you don't need to feed that. You cannot digest food. You're not going to be, I also tell people, if you're running from a tiger, you don't want anything sticking out like in men. So 85% of
Right.
men with PTSD have sexual dysfunction, which is kind of an interesting number. So if you look at it from that perspective, right? So now you run away from the tiger, you're sitting in a cave, but you're going to be sleeping with one eye open. You don't want the tiger eating you, right? That's kind of important. And whenever you're walking around, you can be hyper vigilant because you're waiting for the tiger to strike you. But it gets actually deeper than that. It's smart. I mean, our bodies are crazy, amazing to me. So epigenetics is you can change the DNA. There are two ways to do it. One is mutation, which like get beamed by radiation, or genes can respond to stress in the person. So that can actually change the DNA. And actually, I wrote a paper on that. What's odd about it also, you want your children also to be hypervigilant to make sure the tiger doesn't eat the kids. So now if you look at, like for example, in my space, my grandfather was always beaten to death when he was in Ukraine. He gave those genes to my father, who was involved in World War II. Out of 10,000 people in his squadron, 100 made it home. He gave those genes to me, so I got PTSD from him, right? You can inherit PTSD. And just to make it more interesting, if you think about it, if you have the caveman and he can't sleep and whatever, then he beats his wife, she gets PTSD. That's called secondary PTSD. And I mean, that sounds kind of semi-funny, right? Caveman, but let's look at the military. So a lot of those guys come home and they have a horrible temper and they drink too much. And the same thing happens to kids, right? So they come in and you don't know what kind of person you're going to see, a nice dad or a mean dad. So what we're trying to do is treat primary and secondary PTSD or PTSI. So it's all connected, but
That's amazing.
it's adaptive, right? I mean, it was adaptive then, but now it's not adaptive. You can't run away from the stress of a job.
Right, right. Our body thinks it's doing us a favor by working to keep us alive. Our environment's changed so much today that we obviously don't have the same attacks, and we don't have lions and tigers come and hang around us. But our brain and body doesn't really know that, so it's still running on those circuits to keep us alive. So yeah, you tell an amazing story in the book about a soldier who came to you who was, I think he woke up in the middle of the night and he was strangling his wife or something like that, kind of, and he was like, either I'm going to do something terrible, or obviously she's going to leave me if I don't do something like that. And y'all have got a number of amazing stories. But when someone comes to you, let's dive into the actual procedure, and then I want to kind of get into some of the development around it. So when someone comes to you like that, you have them run through a few things that we've talked about. So they do a questionnaire that kind of gives a pretty in-depth discussion around the symptoms that PTSI would include, correct?
Well, so now I'm fortunate to be able to be the chief medical officer for Stella Center. So we are actually an international organization. So We used to do just PCL, which is questionnaire, standard screening personnel. We've gotten more specific. Now we have psychiatric nurse practitioners who talk to them, do the PCL, do the analysis of anxiety, depression, and other things. And sometimes what we find, especially in special forces, they minimize their symptoms. Go, I have no problems. Nah, no problem at all. But then if the number is too low, we can't really do anything about it. So we do a more advanced version. It's called CAPS. And to the person, we find a lot of things going on. And if you ask the wives, they'll go, "Are you kidding me?" The answer, zero on this one. That's like a 10. What are you talking about? Uh, so screening is first, always. But
Yeah.
now we're pretty sophisticated about it. So in order to be a potential candidate, I think that may be one of the things you're asking. There is a psychiatric screen, because if they don't fit that, then there's no reason to proceed. Two, they need to be physiologically healthy, meaning they don't have blood thinners on board, they don't have a bad heart or bad lung. It's still a medical procedure. So we screen for that. We've been doing it. I and my assistant's been doing it for 17 years successfully, thankfully. And then it's like I'm a medical doctor. I'm not a psychiatrist, and I'm proud of that.
So, and then do y'all do imaging on that front end? Are y'all doing any kind of, brain scans or anything before you get the procedure started?
Unfortunately, we don't have the financial capability yet, but we're about to start doing it. In fact, recently I had a brain scan done on me, and I'm happy to report I do not have PTSD because I was treated, and my brain is younger than my stated age, which I was excited about. There's another lady that we did scan. We knew she had PTSD, and it was interesting. Her right-sided amygdala was significantly larger than it should be for her age, and we treated her. We're waiting to repeat the scan. We don't do it routinely because it just, it's expensive. Who's going to pay for that? It's certainly
Yeah.
not covered by insurance. But if you look at Jason Brown, the guy you were talking about, so Jason did had a fMR before and after. He did show a big amygdala, right-sided, and then after the block, 2 days later, it was smaller, and his symptoms went away, which was really cool.
So do you think that's part of the kind of pruning process after as well?
No, 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 you can't see the pruning. Pruning are really tiny, microscopic fibers. What it is
Yeah.
if you look at the amygdala, is part of the limbic system, right? So if there is a lot
Right.
of sympathetic tone, amygdala is activated, so it gets bigger. So if you reduce the tone, it shrinks.
Is
Microfiber.
there any other
Good.
is there any other signs on kind of scans that signify PTSI? So the
Um,
size of the amygdala is kind of the telltale sign, but is there anything else that jumps out to you whenever you're looking at those things?
Frankly, I'm not a neuroscientist. Some people do say, there is a prefrontal cortex shrinkage or change. It also depends on the scan you're using. PET scans sometimes give more information. That's nuclear scans. But I primarily talk about amygdala because I understand it better. The
Yeah.
insula can also change because insula and amygdala talk to each other. And the other part that people really don't quite appreciate is if you look at the soldier's brain who was involved in serious combat, 24 years old, Jason, he was 24 at the time. His brain was about one third smaller. It actually shrinks. PTSD shrinks the brain. And if you think about it, the reason what's amazing about human brain, our prefrontal cortex controls the amygdala. There is a direct connection between the two. And if prefrontal cortex shrinks, you can't control the amygdala, so you can't control yourself as well. Think of a child. The prefrontal cortex is not developed yet. Temper tantrums, easy emotional liability, kind of sounds similar to PTSI, right?
So let's get into let's kind of get into the procedure. Let's geek out on this thing a little bit. So when you're going in, talk me through the procedure of what does it look like? What are you looking for whenever you're doing the procedure? And let's go with like the gold standard. Let's talk about the DSR and kind of how that procedure works and what's it actually doing in there.
Sure. Well, there are a couple of components to that question. So the first thing we always do is after we talk to the patient, sign consents, all the usual, we put an IV in. About two-thirds of the people come and see me prefer to do it with sedation so they sleep. When I had mine done, you can, if you want to see me being stuck in the neck, you can go to my YouTube channel. Um, so basically, we give sedation to two-thirds. One-third people just want to do it local, which is not a big deal for me because I'm sticking the needle. So that's not a problem at all whatsoever.
Right, right. I don't
So
feel a thing.
I feel nothing. So then we put some goop on. We use ultrasound guidance. And when I teach people to do this procedure, the number one thing I teach people where not to go is number one, where to go is number two. So safety first. So the cool thing about ultrasound, you can see what the blood vessels are. So, uh, so we can find the blood vessels. Obviously, if we avoid those, we see what the bones are and the nerves are. And then I have something called echogenic needle, the needle that lights up with ultrasound. And under guidance, so I can see at all times where the needle is. And my assistant then injects a little medicine, which is local anesthetic. And then I see if it goes in the right place. And we put half a syringe and I reposition the needle and finish it. And I go to a higher level, which is called C3, C4 level, and we do more of it. And I'll tell you where that came about. It's kind of an interesting story. And then we're done. The whole procedure takes about 5, 7 minutes in my hands. And then in the recovery room, you watch people for eye droop. So it's called Horner syndrome. When you do a
Yep.
sympathetic block, it's a very complicated reason why it happens. But the eye starts to droop, the pupil gets small, and eye becomes red. So that's kind of the story.
Yeah, it's such a different. I want to explain to people what this used to be because sympathetic blocks have been done for a long time, but probably in what the last 15 years or so, we started using ultrasound more or image guidance. But what a doctor used to do was just basically feel along the neck until he felt the C6 tubercle and then just kind of jam the needle straight in. You have a lot of structures there. Obviously, we're looking at it. You got carotid artery there. You got jugular vein right there. We certainly have quite a few smaller blood vessels and nerves through there. So probably there was some portion of time where they hit it just right. There was probably some portion of time where they hit it just right, and the patient woke up with some bruising in his neck and arm or her neck and arm. So the ultrasound guidance has made this just so much more precise. So are y'all going through, are you going through like the anterior scalene and coming from the side, going through like a lateral approach to get to it?
Wow, you're so technical. You're so technical. Okay, let's get technical. So first of all,
Yeah, let's do it.
I first time stellate was ever done was 1926 in France for asthma. First time I personally did stellate ganglion
Wow.
was 1987, blind as you say. So there is anterior tubercle protrusion, Schwarzkopf's tubercle, and yeah, then you kind of hoped, and that's why the volumes were larger and it was a problem. Yeah, so I don't always have to. Anterior scalene is back here, plexus is here, brachial plexus, and then the middle scalene. But a lot of times I go in front of anterior scalene, and I see the anterior tubercle for C6 level, and I bend my needle and I slip right over that. That's where the ganglion sits. I don't know if that
Love it.
maybe too much detail, but that is what it is.
I think we'll put some pictures up for those of y'all who are listening to this, and if you're watching this, we're gonna throw some of these up because I think it helps people to understand like your stellate ganglia lays on the front side of the neck, so it controls so much of the sympathetic response in the body, and it's this kind of long, star-shaped ganglia, right? That really, is in charge, or at least in the peripheral part of our sympathetic response, this fight or flight response.
So
When I was go ahead.
let me give you some information I think would be very interesting for you. So clearly you
Yeah.
understand this whole thing. So C71 ganglion is called stellate ganglion. It looks like a star. So we're actually at C6. C7 is not as safe, and that's why we go higher up. But if you put a retrorabies virus, you can actually chase around into the ganglia in the rat. You can see a connection from the ganglia here to the amygdala and the insular cortex. So we know there is a connection, and there is a lot of sympathetic nerves go down the arm. right? So
Right.
you're 100% right. Yeah,
Yeah. So so you go in there and you're just putting, kind of a typical anesthetic block on it, correct?
correct. Local anesthetic. So bupivacaine is what we usually typically use. Nothing else in
Which
it.
is so, when we think of an anesthetic, if you're having pain in, let's say something that somebody knows, carpal tunnel, and you went in and you injected an anesthetic around the median nerve, it would, hopefully, if we're diagnosing that correctly, it would change the pain that you were getting from that nerve. So it's such a fascinating thing. I love this. It's one of the most amazing techniques that I've kind of come across in the last decade in terms of what we can do for people. If we're talking about something that is controlling our kind of emotional and fight or flight response, that sympathetic response, and we go and we inject an anesthetic to that. Take us through the process of that changing somebody going forward. What are the things that, you talked about in post-op? What comes next? What starts to happen to them after that?
Also, back to what we were talking about, the NGF, nerve growth factor, that start in the brain and then transmitted through sympathetic fibers to the ganglia. So, so the sprouting I was talking about is called NGF dependent. So when I do the local anesthetic injection under the ganglion, the first thing that happens is norepinephrine production stops. And norepinephrine is being absorbed in the brain. So in 10 minutes, there's no increased norepinephrine around the brain. So that's why the symptoms get markedly better immediately.
Yeah.
But since the sprouting is NGF dependent, if you take away the NGF, whatever the reason, and there is a complex reason for that I won't bore you with, which nobody quite understands, but local anesthetic knocks out NGF. So NGF requirement goes away, and that's why the pruning happens.
Love it. Let's go back to the going up to C3, because I think that's one of the main things that separates DSR from like what there's great research. I'd love to if you have some of it on just doing stellate ganglion block.
Yeah, yeah, of course.
But the DSR is kind of that next level up. Tell us about your discovery of that and how that came about.
Yeah, it's actually one of my favorite stories. But as far as research on SGB or stellate ganglion, if you go to my website, drugenelipov.com, I have a lot of my publications there and other people's that talks about SGB. Anyway, so I was taking care of this guy who was sniper from the Marines, and I knew him because I burned some nerves in his back for his back pain. He came in and he was crying, and his wife was crying. It was extremely sad. And he said, "I'm going to kill myself." And I said, "Okay, let's put you in a hospital." He goes, "No, I'm not going to be admitted in the hospital." Anyway, one way or another, he said, "I just want the shot. If I go to the VA, I'll die there." So we go to the operating room. I do the C6 procedure, stellate, and nothing happens. I'm looking at him 40 minutes later, and I was to say I was scared is an understatement. So before I got to the PTSD ward, I was doing procedures for hot flashes. So the government of Norway invited me to go um, teach them how to do stellates for hot flashes. So when I was there, I learned how to do a C3 superior cervical ganglion block. So basically, there are three ganglion in that. Stellate ganglion at C7, middle cervical ganglion, and superior cervical ganglion, which is the biggest one by far up here. So back to the soldier. So we do the procedure, or Marine, sorry. So I do the procedure. 5 minutes later, he comes out of the operating room, gives me a high five. He said, "Doc, I'm feeling great." And he did like 7 years we followed him. He did great. So I go home and I was like, what? Why? How? Why? I have no clue. Because the people who trained me to do stellates were arguably Dr. Ellen Winnie was the man in stellate space in the 70s. He was an amazing man, anatomist. Uh, in fact, I tried to understand why stellate lasts for a long time. He said, "Don't ask dumb questions." I was like, "Thank you for that input. Thank being a real professor. I really appreciate that." Anyway, so because nobody's ever done dual block, and I was like, that's crazy. So I found a book by James Moore from 1956 that had a great anatomical chart. It's been out of print since 72. Turns out sympathetic fibers start at T2, which is the highest level sympathetic fibers lives the spinal cord. Then they go to C7, T1. Then half of them go to certain part of the brain following vertebral artery. So there is an artery that goes from the neck to the brain. Half of those fibers go up to superior cervical ganglion and go to a different part of the brain following internal carotid. So what I'm thinking is when we were doing only C6, we only did a partial reboot, so to speak. So when we're doing
Yep.
dual, that's why it's more effective.
I love it. And the reset even, it almost is doing a reset button, on somebody who's had an injury to those nerves. You go in and you turn that off, and then when it comes back on, it's recalibrated, for lack of a better
Well,
term.
I use that explanation because people are familiar rebooting their computer. Like, it's dragging, it's not moving right. You reboot it and it works better. So it's kind of, to me, similar because people come in hypervigilant. And the thing I love seeing after I do the procedure, I've done about 3,000 now, but they have this big smile in their face and they go, my God, I'm relaxed. Their shoulders, they come in like this. And it's like, oh, okay, I'm good. How you doing? How you doing, hon? It's like, they give their spouses high five. I got to tell you, it never gets old.
No, no, I'm with you. I mean that, and especially somebody like that, because they lose hope so much.
Right.
That I've taken everything. I've done all these things, and it's not working. To even just to hear this and somebody out there to have hope, I think is just massive with what you're doing. It's amazing. You talked about hot flashes, and one of the things when I was reading this book, I started to try and like how many other areas can this be effective? It started just to kind of rattle around my head. So, let's go off label for a little bit. People who have dealt with chronic stress, you talked about women being the number one thing. I think of so many different types of people who, are resistant to other types of treatment. What are those things that either anecdotally y'all started to see this help with? What are some of those stories? I'd love to kind of put some of those out for people to hear.
So I mean, it's kind of interesting. So I recently had the honor to take care of some SF, personnel special forces from Green Beret and Delta Force, people like that. So a lot of them are, it is used to be taking, used to be ADD medications. After we've done the block, they don't need the medications because they're more clear, which is, if you think about how that all works, I think that's amazing.
Yeah.
Hot flashes thing could potentially be life-saving because if you look at hot flashes, so if women have breast cancer, let's say, so if let's say they have mastectomy or whatever surgery, and then they're placed on aromatase inhibitors, which suppresses estrogen level, in order for it to reduce the chance of recurrence of cancer for about 30-40%, you need to take for 5 years. Those drugs unfortunately produce severe hot flashes. And women, even knowing that's what you need to do, 50% stop taking it in the first 6 months because the hot flash is so bad, they can't live their lives. They can't sleep, they can't have sex. I mean, it's terrible. And then and they can't take estrogen, obviously, because of breast cancer stuff. So that's where I think it's so important to do it. And also menopausal depression and all of this leads to all type of problems. And potentially this could be a huge change. Those are two things we've studied and it's been replicated in a number of institutions now. The other one that's kind of interesting, which I really am not interested in dwelling in, but I'll tell you what I've read about. Uh, there was a report, the first report of somebody who was schizophrenic in Japan. He got kicked off the horse, fractured his shoulder, and they did stellates for shoulder pain. The first block made the voices, who were nasty voices, go away and became conciliatory. The second block took away the voices, which is interesting, right? Crazy. So we've treated a couple of, it's called psychoaffective disorder, which is type of schizophrenia-ish. But what's interesting is amygdala also controls schizophrenia. And those are the two specific. There's, if you look, the first stellate ganglion block was done for asthma. So it controls immune system, which is another crazy thing. I wrote a paper on that. But there was a paper out of China where they took people with ulcerative colitis, which is an autoimmune system, and they were able to, doing stellate, they took away the symptoms, and interleukin 6, which is one of the inflammation factors, was dropped. You can actually measure that. So I think as we go forth, more and more indications will be used. Also, stellate's been used in Sweden to reduce size of a stroke, which is kind of nice little effect by 30-40%.
Yeah.
It's a huge deal. Um, it's been used to reduce TBI, brain change, traumatic brain injury. So it has a fascinating potential, and I've been trying to get the military to engage in it. We're not there yet, but we're moving in that direction.
Yeah, I had a patient who came in after an anterior approach neck surgery,
Mhm.
and was having good recovery, but was having a lot of what you would consider very high stress kind of PTSI style symptoms.
Thank you.
And I was reading your book, and to be frank, like, we've done a lot of ultrasound guided needling around the front, but hearing yours, and one of the things I thought about with it is, a lot of the trauma was at C6, but no one's ever thought to go up on her and look upwards at C3. So as soon as I like put the book down, I'm like, we need to get her to someone. And for something that's a safe procedure, that seems to almost have pure upside if it's done on the right person under these conditions.
Well,
It's hard to not recommend it for somebody, right?
well, I appreciate it. But it's like, again, I'm very careful. You need to be, I have obsessive compulsive disorder when it comes to this. But I think if it's done well, it's a safe procedure. You just need to be prepared for problems. Something like that, by the way, hydrodissection of stellate ganglion may be helpful, and C3. And then, we can talk offline about this type of patient if you're interested, but I think we'll bore the general audience to death with that. But, it's interesting when people do like anterior surgery, as you say, they're not really violating that space directly. So it doesn't seem to affect it. Like, I've taken care of people who have fusions and all that kind of stuff, and we'd be able to navigate it.
Yeah. Yeah. So you kind of mentioned this, and I at least want to kind of get it out there. So the invisible machine, as you call it, is this kind of play on the words of this invisible response, this invisible injury, so to speak. And
That's
you're
not what we called it. I'm sorry. Nope, that's not the name.
no,
No, invisible machine, the name was there for invisible sympathetic system. Most sympathetic fibers are tiny, right? You can see the
yeah,
ganglia, but most are too small. That's why we called it. But
yeah,
you can call it the other
gotcha.
way too if you like. No problem.
Yeah, everybody kind of. I won't go through book naming stuff with you. We've gone up and down on mine, um, and then so y'all are getting this procedure out there through your clinics. Let's talk about that. How do people find Stella clinics? Where are y'all in the States?
So, stellacenter.com is our main website. So I'm chief medical officer for this organization. That's how you can find it. I think we're in most of the major cities, New York, Chicago, LA, um, San Diego, I think Dallas. There's a number of other, I don't remember. We have 35 providers across US. We have three in Australia and one in Israel.
Beautiful. So for those people who are kind of listening to this, and they're like, look, I've had some of the symptoms that y'all have talked about. What would be your kind of follow up? So if somebody does this, what's the next steps for them? Should they be, there's a lot out there. What are some of the things that you've seen paired with DSR that really, worked at that very deep level? Y'all talk a lot about the advanced, kind of treatment for some of these things, EMDR and a lot of those things. What are some of those follow ups that you've found to be really effective?
Couple of things. One is meditation. That's the only thing that's been shown to grow your brain tissue back. Do monitoring, this Oura ring. I mean, I'm not saying that's the only way to do it, but there's many ways to do it. This way tells you what your sleep is like and things like that. Um, CBT or cognitive behavior therapy, I think is very helpful but it needs to be trauma-informed person doing it. Get exercise, eat well, don't drink too much, knock off the drugs. In fact, a lot of people are able to stop drinking like that, even very heavy drinkers, without withdrawals, which is to me still, I'm still, that's something I'd like to study. So,
Yeah.
basically have a normal life. And the other part that's I think a lot of men would be interested in, I wrote actually a chapter on reversal of sexual dysfunction from PTSD. Because, people, it's like, think about it, if sexual dysfunction in men leads to unhappiness in family, abuse, all the usual praise. I used to be an ER doc and trauma doc. I used to see all that. So absolutely. So go for walks, and then it's amazing how you can relax. The other part to remember that whoever is your spouse is, or partner or whoever, you need to remember they may also have PTSD, PTSI. Get them treated as well. Be cognizant of that. Because when people come in and they
Yeah.
touch you, it's like they're jumping. Those are symptoms of PTSI. No, you haven't been in the battlefield. No, you have not been raped. But people don't realize just how horrible walking on eggshells is for you. I've lived that life. It's extremely uncomfortable.
Yeah. Yeah, I immediately thought, in the section of the book of someone saying, like, well, haven't been in battle, so I cannot have it. And y'all do a great job of saying, like, no, it's not that. It's the experience and how it affects you personally. And I couldn't help but think of how the last 3 years has affected so many healthcare people in a very traumatic way, and how many of those people are still dealing with it. A lot of them changing careers and
Right.
changing lifestyle, and you start looking at that, and hopefully that's getting them healthier. But if they're not, to have something that can go in and kind of reset that system and help heal the injuries that that these traumas have caused is fantastic.
Well, the other thing that's weird is COVID virus itself increases sympathetic tone. So it's actually COVID itself, the virus, not just mental, but physiologically can give you PTSI. So there's unfortunately mental health has degraded. It wasn't that great to start with, but it went downhill after COVID.
Yeah. Yeah, I mean, and we can just kind of touch on this a little bit. Do you see, especially as you start trying to change the language? That's why I'm going to really try and make sure we do a good job of saying PTSI on these things. As you start to try and change the language, do you think that is at least one of the lead dominoes that can filter out to changing the stigma around mental health? Because we do see it even today, as much as we start talking about it, it's still this thing that brings a stigma, that brings shame with it. If somebody's like taking a mental day, you see online, everybody kind of goes crazy and almost still, kind of laughs about it, jokes about it. There's still the shame and stigma that's attached to it.
Well, for sure. In fact, I did a study on that. Based on 3,000 people, we found that if the name can be changed PTSD to PTSI, then the stigma will get better and people will get treated. And that will save lives. So we have a huge campaign going around that right now. In fact, I gave a speech at APA, American Psychiatric Association, about that this year. So one of the major proponents of the name change has been Frank Ogberg. I think we talked about it before. And his buddy was Peter Chiarelli, a four-star general in charge of prevention of suicides. So General Chiarelli and I just connected actually this week. So we're going to start to increase this campaign. Peter and Frank tried to make that happen 11 years ago. I told Peter that I'm going to be making that happen within a year. That's kind of my goal. He said, if it happens, he's buying me a beer. I'm going to hold him to it. But The time is now. If it's not you, then who, right? I mean, I'm a huge believer in that. And the reason I'm so passionate, just so you know, my mother took her life when I was an intern, surgical intern. So one name change can save tons of lives. Why not? And why not now? I mean, how many more lives do they have to lose unnecessarily?
Yeah. Yeah. Dr. Lipov, thank you so much for everything you're doing, the information you're putting out there. I can't let you leave. We ask all our guests, if you could tell the people listening to do one thing today to improve their health, what would the one thing be?
Stop during the day for 5 minutes and just meditate. Just close your eyes and just calm down. 5 minutes. Just ask
That's it.
5 minutes every day. People I work with, I come around and I go do this to them. They go, okay, all right, fine. I'm sitting down. I'm calming myself down. 5 minutes. All I'm asking.
I love it. Fantastic answer. Thank you so much for joining the Pain and Performance podcast. Thanks for everything that you do. And we'll hold up the banner on PTSI with you. We'd love to see that
5 minutes.
year out. Take your 5 minutes. I love it. Thanks so much, Doc.
Thank you.
Have a safe flight.
Thanks, Derek. Thank you so much. Take care.
You're welcome.